Good afternoon, all of you. Myself, Dr. Deepen Bua. Thank you, ma'am, for the kind introduction, and thank you, IMS Surat, for a wonderful opportunity and giving me opportunity to present the presentation and discuss the what is new in medical oncology. Thank you. So today, traditionally, we are knowing as a medical oncologist, we were only known as a chemotherapist. No advancement were happened in a field of oncology. So it was basically in a stage 4 malignancy, it was considered as a dry state. So since last 1.5 decade, especially since last 10 years, significant advancement are going on in the field of oncology, and I'm here to discuss these all. And further, I'm starting. So highlight of today's presentation, that is a cancer statistics of a common cancer that my earlier speaker, Dr. Amit Gupta, has discussed. Evolution of the cancer therapeutics, newer options in a cancer treatment, that is starting from the chemotherapy, starting from the chemotherapy to target therapy to immunotherapy, immunotherapy to antibody drug conjugated therapy, and the CAR T therapy. And if time permits, we will discuss also a case discussion on a lung cancer, what we do daily as a medical oncologist with the metastatic CL lung patient. As this therapy option I discussed theoretically, how we apply in a clinical practice, or modalities of systemic therapy, that is a chemotherapy, target therapy, and immunotherapy. Already discussed by Dr. Amit Gupta, cancer is a pandemic now. Incidence is alarming and rising day by day, and Asia and India are contributing significantly. If we see Global Cancer Advisory data, that is the largest registry of worldwide cancer cases, nearly 18 million cases in 2022 has been reported. If we see the incidence, the lung cancer as expected topping the list 13%. In female, breast cancer follows closely, that is 12%. Lung cancer in both the sex, female cancer in only female 12%. Colorectal follows that 9.6, prostate cancer 7.3, and stomach cancer is the fifth most common cancer, that is a 5%. And mortality wise, lung cancer topping the list 20%. 1/5 of the cancer related deaths are attributed to the lung cancer. Colorectal 9.3, liver nearly 8, breast cancer 7, and stomach cancer 6.8. In India, is it expected oral cavity cancers in male, most common cause of death, is observed. If we see the data wise, what is the cancer prevalence and projection over next 20 years? So starting from the way back 1975, where prevalence was nearly 4 million cases. But over a period of 25 years, in 2000, nearly case numbers were double, and 10 million cases were reported. In 2024, it is, as I already discussed, 18 million cases has been reported, and it is expected that in 2040, the incidence will rise to 26 million cases. How to combat that? Already discussed in earlier presentation, we should quit the smoking and heavy alcohol consumption. This will reduce the cancer burden by almost 50 to 60% of new cases. Vaccine preventable cancer like hepatitis B and C, hepatitis B that causes the chronic hepatitis B infection causes the HCC, hepatocellular cancer, and another cancer, that is a cervical cancer, HPV vaccine, that both helpful for the prevention of the virus causing cancer. In the screening of the disease, if we detect the it is proven fact, that is, if we detect the cases early by screening modalities, breast, colorectal, and cervical cancer, these three cancers have a proven mortality benefit proven screening methods. If we do that, then we can reduce the mortality as well as the increase the survival chances. In prostate, yes, it is, of course, at present data is not substantially proving the mortality benefit, but it significantly reduces the high number of risk cases. As in prostate cancer, at the age of 80, nearly 80% male prostate have a cancer, but not always all patients need to treat, because throughout the life, without any investigation, person may survive without any difficulty related to prostate cancer. So if we screen, we can identify the prostate cancer that is a high risk earliest. In a negative aspect, you will overdiagnose. No need to treat. Lower risk cases, you will unnecessarily treat. So risk and hazard, both risk and benefit both are there. So you need to decide based on the profile of the patient. Another case is lung cancer. In a significant history of a cigarette smoking, nearly 20 pack years, and those who have continued the smoking or quitted in last 15 years, those people are advised to have a HRCT annually, because these people are having a higher risk for the developing lung cancer. But despite of this fact, who will conduct the, who will undergo the screening modalities, because each and every cancer has a different screening methods. So one test fit for all, it is not possible. So what is the next? Improvement in treatment modalities is the next. What we can do by that, improving the treatment modality, that is the unmet need today's date, by which we can improve the survival. Evolution of the cancer treatment. As usually, list is dominated by the surgeon initially. Surgical treatment in 1890. Surgical removal of the tumor, pioneered by the William Halsted. That is a father of a mastectomy. Modified radical mastectomy was done, and at that time surgical oncology, surgery was the predominant mode of a treatment. Then after radiotherapy came into the picture in end of the 19th century, X-ray was proven to be beneficial for the treating malignancy. In a chemotherapy, then after chemotherapy, then after targeted therapy, then after a latest advance in the cancer field, that is the immune checkpoint inhibitor, came into the picture. This is the what I already discussed. So in today's lecture, I will discuss not chemotherapy, but the advanced to that, target therapy and the immunotherapy I will discuss. Target therapy is a that can be a small molecule or a monoclonal antibody. Small molecule is a typically developed for the target that locate inside the cell. That is basically a tablet or an injection that goes into the cell, and such agents are able to control the cancer relatively easily. And second target therapy mode is the monoclonal antibody. That is a large molecule, basically cannot enter into the cell and bounds to the cell surface receptor and produces the effect. Small molecule kinase inhibitor, that basically a cell surface receptor. The receptor lies across the cell membrane, and the intracellular aspect, there is a tyrosine kinase binding domain, where this molecule goes into the cell and binds to the ATP binding cell site, and then exerts their anti-oncogenic effect, inhibits the gene transcription and cell progression. These are the approved TKIs in various cancer has been till now. Imatinib, with the advancement of the imatinib, that is basically a tyrosine kinase inhibitor, CML, GIST, these are the diseases like a cold disease. Earlier used to be in CML, there was a chemotherapy and bone marrow transplant was the only option for the cure were available. With the advent of imatinib, with the 10-year survival nearly more than 70%, out of 100 patients, more than 70%, with the tablet only, they are controlling the disease since long. Dasatinib, linotinib, gepitinib, erlotinib, these are the various TKI. Gepitinib, erlotinib are in a lung cancer, lapatinib in a breast cancer, sorafenib in a kidney liver cancer, and sunitinib in a kidney cancer. These are the second target molecule, that is the monoclonal antibodies. We all know this is the source of monoclonal antibodies. Mouse for predominant structure, chimeric mixed various proportion, humanized with the more of a human contribution, and human is fully human. This is the naming. Prefix is a fix based on the target system, that is circulatory, immune system or tumor. Stem is given to that, and stem is to the source of a monoclonal antibody. In small molecule, the molecules like a TKI, tyrosine kinase inhibitor, based on the site of action, that is a TNIP, tyrosine kinase inhibitor, ZOMI, proteasome inhibitors, that is used in multiple myeloma, cyclips, cyclin dependent kinase inhibitor, that is a tablet form of therapy available for the metastatic breast cancer, and the PARPs, that are the new molecular therapies, inhibits the PARP, poly-ADP ribose polymerase inhibitor. Various type of monoclonal antibody. There are plain monoclonal antibodies who have no drug or radioactive material attached to them. If the drug is attached to them, these called as the chemo-labeled antibodies. These are the advancement into the monoclonal antibody. These various molecules, brentuximab vedotin, TDM, TDXD, sacituzumab govitecan, and enfortumab vedotin. These are the all molecules. With the evolution of the monoclonal antibody, combination of the antibody as well as along with the linker, the chemotherapy drug has been attached to that, and they are called as the antibody drug conjugated. And this is the new molecules in a cancer treatment in a various system-wise cancer. Brentuximab vedotin in lymphoma, TDM and TDXD. They are respectively in use in a HER2-positive breast cancer. Sasitumab govitecan, a TNBC variety of breast cancer, triple negative form, and enfortumab vedotin, that is the metastatic urothelial cancers, in that it is used. And if the monoclonal antibody is attached to the radiolabel antibodies, that is the ibritumab TUX taken in atrium 90, radiolabel, that nuclear ligand attached to the monoclonal antibody is a new entity. This is the pictorial of the ADC, antibody drug conjugate, in which the conventional antibody structure along with the blue color, violet color linker that is attached to the chemotherapy molecule. So what is the benefit over the conventional chemotherapy is that antibody FAB portion, antibody binding portion, identifies the target molecule to which target it should attack, and then selectively to those target with the linker that cytotoxic chemotherapy molecule delivers its effect. So this is the advancement, as earlier I stated the molecule's name. Another advancement is the bispecific monoclonal antibodies. These are the not a complete antibody, but the two different antibodies FAB portion, antibody binding portion, that is a Y-shaped structure, and FAB binding portions of that binds to the CD3 of one antibody portion attached to the CD3 and one attached to the CD19. That is basically a hematolymphoid malignancy. For that hematolymphoid malignancy, this structure is two different portion of an antibody attached with the linker. And what is the rationale of this molecule is that it interacts with the cytotoxic T cell of the body, that is a host, and the leukemic cell, B cell antigen, CD19 expressing B cell. It let the interact both the molecule and then fire. So it enhances the anti-tumor efficacy. So this is the bispecific antibody. These are the FDA proven maps in various cancers, starting from the list rituximab, that is the anti-CD20, and followed by the trastuzumab, anti-HER2, alemtuzumab, anti-CD52, cetuximab, bevacizumab, and panitumab, then colorectal cancer, and further ofatumab is again CD20, and brentuximab vedotin, that is the ADC, pertuzumab, that is the plain monoclonal antibody against HER2, trastuzumab M10C, that is a HER2 positive breast cancer. Further advancement, this, if we see the evolution, in this list earlier used to be a plain monoclonal antibody as per the approval year. With the significant advancement, these all, since 2011 onwards, all are antibody drug conjugates. So this is the monoclonal antibody. The world is receiving new molecule in form of ADC rather than plain monoclonal antibodies. These are the common routine practice monoclonal antibodies. Another molecular target is the PARP inhibitor, poly-ADP ribose polymerase inhibitor. That is basically related to BRCA mutant, breast cancer gene associated cancers. Which are the cancers? Breast cancer, prostate cancer, pancreas cancer, and ovarian cancer. In breast and ovaries, 5 to 10% of the cases are related to BRCA1 and 2 mutant cancer. That is basically a hereditary or familial cancers, in which these molecules have a role. In a PARP, it basically poly-ADP ribose polymerase is basically single-stranded DNA repair enzyme. In a BRCA mutant, double-stranded DNA repair is deficient. So who will take care? ADP, PARP inhibitor. By single strand repair, it will take place, but with the medicine of a PARP inhibitor, that is basically a PARIBs, olaparib, niraparib, rucaparib, and telezoparib, which inhibits the single-stranded DNA damage also. So it will cause the synthetic lethality. It will not let the deficient tumor, BRCA deficient tumor to repair. So by that, it will enhances the tumor death. Hormonal therapy. We all aware that in hormone positive breast cancer, that is the majority of cases of a breast cancer, 65 to 70%. This aromatase inhibitor is given as the adjuvant therapy as well as the metastatic setting. In estrogen receptor downregulator, that is the fulvestrant and elacestrant, and CDK4/6 inhibitors, that is Ciclib, palbociclib, ribociclib, and abemaciclib. These are basically CDK4/6. These molecules have changed the treatment landscape of the breast cancer, because initially, after 2017, this molecule has been came into the practice. Before that, there was this limited survival with this one aromatase inhibitor or hormonal tablets. tamoxifen, aromatase inhibitor or fulvestrant. With the nearly 2.5 year survival was there. With the advancement of this molecule, MBC has crosses, metastatic breast cancer, hormone positive has crosses the landmark survival nearly 5 years. It was not imagined earlier in a metastatic breast cancer which causing the survival of 5 years. In prostate cancer, LHRH agonist, leuprolide, antagonist degarelix, AR agonist bicalutamide, enzalutamide, and darolutamide, and apalutamide. These AR antagonists, these have significantly changed the outcome of CRPC, castration-resistant prostate cancer, with the longer survival, with the durable, with the tablet type of thing which controls the disease for a longer and gives a survival for a years. This is the already I discussed MBC, palbociclib, and letrozole is the advancement 2015 onwards. This is the response pattern with the tablet form. Initial burden of a disease in first scan with the predominantly breast and mediastinal node. In later scan, there is significant resolution after 6 months. This is the response to the treatment. And the now prevailing topic, immunotherapy. Immunotherapy is basically a tumor cell and the host cell, that is the interaction. We know our body immune cell identifies the foreign cell as a foreign or a body own cell as a own cell by the MHC restriction along with the co-stimulatory or co-inhibitory molecules, so that a self antigen cannot be self cell cannot be killed or the host antigen cannot be escaped. So what basic mechanism behind this? That is the PDL1 is a program death ligand expressed by the tumor cell, and program death ligand by receptor is expressed by the immune cell. If this interaction is there, then the immune inhibitory environment is there and immune escape. Cancer cell will not be cured. If we give a PD1 or PDL1 inhibitors, then this inhibition or breaks for the immunity will be relieved and the anti-cancer effect will result. These are the molecules, pembrolizumab, nivolumab, and anti-PD-L1 inhibitors, atezolizumab, durvalumab, and avelumab are the in clinical practice. Nucleotide block, CAR-T, chimeric anti-T cells, these are the T cells of humans which are genetically modified from the outside, and the receptor for the patient having a tumor, that is, if suppose patient has a B cell tumor, B cell lymphoma or a leukemia, anti-CD19 receptor has been genetically introduced into the T cell and then after again infused into the body. So this is the structure. CD19 of a tumor cell that is expressed and a receptor which is genetically manipulated on the T cell. By binding that, it produces the anti-cancer effect. These are the various evolution of a CAR-T cell in which on the exposure to the dead cell, it increases the proliferation and increases the cytotoxic efficacy of a tumor. Why CD19 has been targeted? Because it is only present on the tumor cell, not on the normal cell. So CAR-T, for the manufacture of the CAR-T, the only preferred target is CD19. This is the manufacturing flow of a CAR-T in which the patient, after apheresis of the T cell from the patient, then after selection ex vivo manipulation by genetic engineering, then after again this genetically engineered T cell cultivated, and then after a day 10, it was after breeding, again transfused into the patient. These are the various CAR-T. Difficult to pronounce, this is the name. These in a relapse refractory leukemia, hardly anything to offer. In which the setting that CAR-T has offered a 90% response rate with the durability of 50 to 60 at the end of 1 year. This has been achieved. These are the various CAR-T options till now approved. With the time constraint, we will not discuss that one. So, as I discussed, target mutation in a lung cancer. In a lung cancer, what we usually do? First is the biopsy. Initially, as a lung cancer, initially was a single disease. Then after it was found that is the small cell variant and non-small cell variant. Non-small cell again categorized into the squamous, non-squamous, large adenocarcinoma. And then after adenocarcinoma was again the molecular heterogeneity, EGFR, ALK, and ROS1, and the PDL1 expression, it was categorized. Initially, whatever we used to offer a NGS for the metastatic adenocarcinoma, if having some mutation in that, we go for directly for the tablet type of a target therapy. If negative, then we used to offer a immunotherapy or chemotherapy option to them. With the initially, before this era, target therapy and immunotherapy, lung cancer has a survival of nearly 10 to 11 months. But after invent of this medicine, this patient I had selected, which was a ALK positive, a target mutation, in which the tablet form of therapy has been offered. See the survival. I had borrowed this slide from the CROWN trial, which is the original trial of lorlatinib, that is molecule tyrosine kinase inhibitor. At the 5 years, 60% survival was there. And in the comparator, 8%. 60% people have a no event. They will still on lorlatinib and continue. And after 4 years, in our case, it was progress. And then after we offered immunotherapy, chemotherapy combination. For that, again, 1 year he has pulled. So 5 year survival he has achieved easily. In a key conclusion and insight, effective target therapy, immunotherapy, ADC, antibody drug conjugate, have significantly changed the treatment old landscape of a lung treatment of a cancer, improves the patient outcome and survival rate. Hence, it's crucial to conduct the comprehensive testing for the driver mutation. We should use implementing a broad testing methodologies like NGS, next generation sequences, at both the point of diagnosis as well as on progression, because driver mutation can change after on a progression, and essential for the tailoring the treatment and monitor the treatment. However, the cost negative side, if we see cost benefit ratio, need to consider in therapeutic decision making, because these are the molecule, these are the patent medicines, and patent medicine have a significant cost. If we see the risk and benefit, these medicines are going to prolong, not cure the disease. So my ideal take on this is ideal treatment is the best treatment, but the best treatment is not an ideal treatment always. Treat the patient, not the disease, in an incurable nature of the disease. However, in curable disease, you can consider the treatment of a disease rather than patient. Thank you. This is my team. Dr. Sheetal Modi, she is a pediatric hemato-oncologist. Myself, Dr. Dipen Bua, medical oncologist. Dr. Hasmukh Bawlar and Dr. Dharmesh Vagasia, two eminent hematologists and BMT physician. We together as a team. Thank you.
Thank you so much. Teachers Day હજુ હમણાં જ ગયો. Polyadenosine diphosphate ribose polymerase, lapatamib, trastuzumab, palbo, ciclib, ribo, ciclib. રાઉન્ડમાં તમારાથી બોલવામાં કંઈ ભૂલ થઈ જાય તો ટીચર 100 વાર લખવા આપે બીજા દિવસે.
Yes, sir, definitely. When I was after completion of my MD, I had immediately, without any preparation of oncology, I had opted medical oncology. Since for the initial 3 to 6 months, I was clueless what is going on with me. I was absolutely clueless. Then with the practicing this molecule very regularly, day-to-day basis, it is habit for me. And then even like that, I am a medical oncology is a branch like it is the architect of a science, because it follows protocol. If you are out of protocol, then it will kick you and it will trouble you, because there is no experiment strategy in that, first thing, and it is like an architect of a branch. So different, I see medical oncology different from the other branches.
Yeah, thank you so much. નામ બોલતા બોલતા જીભના લોચા વળી જાય છે, એટલે no question. Thank you so much.
Thank you.
Thank you, sir. I request Dr. Rajnikant Patel to please come up on the stage, and Dr. Virendra Patidar, sir, to please come on the dais and felicitate Dr. Dipen Bua, sir. A big round of applause.
So